Welcome. I'm Dr. John Martin, Chief Medical Officer of Butterfly Network, and I'm thrilled to bring you this afternoon another version of our webinar experiences where we're learning from people around the world on how to transform healthcare. This is an especially exciting edition tonight because we're seeing the remarkable experience of a group of physicians who've truly embraced the challenge of COVID and transformed healthcare in a way that's going to be long-lasting after the pandemic resolves. And I'm joined by my co-host, Professor Daniel Lasserson, Professor of Ambulatory Care at the University of Birmingham, a consultant in ambulatory medicine at Sandwell in West Birmingham, and under the NHS Trust. I'm going to turn the guidance of this great program over to him. He will lead us through an incredible hour of where we'll learn from what they've done, which is truly inspiring and humbling, and should serve to all of us as a lesson of how you can change healthcare in a rapid and transformative way. And now, Professor Lasserson.
Thanks, John. And thanks everyone for joining us tonight. This is going to be really quite an amazing webinar and discussion. So it would be great to start the discussion off tonight by hearing a bit about the culture and context, where this all came from, how we first got to hear about these changes in healthcare delivery for COVID, and what the potential is for point of care ultrasound. So I love using point of care ultrasound in my practice, both in and outside the hospital. And I think it's time that we started hearing about how these ideas for a new paradigm of care came about. I wonder if I could ask Joe to kick us off and to talk us through where the culture and context and ideas first came from.
Yeah, thanks, Dan. So it all started on the 16th of March when we got a load of documents sent over from a physician called Cristiano Pirani. He's an Italian emergency medicine physician based in Berkshire in Italy. And at that time, Berkshire was the second hotspot of COVID in Europe. And 2 days later, we went up to our 4th floor, and which is where it's sort of like a hotel lobby when you go inside it. It's where all the management is. And we took this idea to them that we needed some of these new butterfly ultrasound probes, and so they bought us 27, which was quite something. And amongst all the documents in this sort of real treasure trove that we were sent was a triage pathway for patients with COVID. And this triage pathway allowed 3 really interesting things. It allowed you to triage patients into those that needed to be admitted and those that needed to be discharged. And the ones that needed to be discharged, if you did a walking test and they passed that walking test, those patients could be sent on to an ambulatory pathway. The COVID ambulatory clinic is what we set up, a sort of virtual ward out there in the community. And during the last 3 months, we've managed over 280 patients with COVID in our ambulatory clinic. The other thing that we were able to do is, instead of just using chest x-ray, the GPs locally were able to use lung ultrasound instead of chest x-ray to triage their patients. And finally, one of the things that was really neat was that we were able to standardize the walking test throughout our region. Because prior to this, there had been a 70-meter and 2 flights of stairs walking test with a 3% drop in SATs, and then a 20-meter walking test with a 5% drop in SATs. So by standardizing this to 30 meters, allowing for a 5% drop in SATs, it meant that a paramedic could phone up from somewhere in the very north of our region and phone up A&E and say, look, I've got this patient who's dropped 8% in his SATs with a 30-meter walk test. They need to come into A&E, and everyone's talking the same language. I think what was quite neat was particularly the COVID ambulatory clinic. So I'd like to hand over to Afi, who's one of the physician associate students, and she's going to tell us really about that COVID ambulatory clinic and how that worked.
Hello, hi, yes. So I'm one of the students that helped set up the COVID ambulatory clinic. And it all began with myself being one of the university students that were taken off placement. Was really keen to help and just wanted to get involved. So we set up the pathway and we just got everything going. So it basically consisted of an ambulatory clinic of about 5 physician associate students. and 3 associate specialists who were quite senior in emergency medicine. And they were there if we needed to escalate or seek any help. So what the clinic comprised of was us calling patients every day for 5 to 7 days, monitoring their oxygen sats, making sure that their symptoms were getting better, but more so just ensuring that they felt safe at home. And more importantly, if they weren't safe, then they needed to come back into hospital if their oxygen sats were low or they were more symptomatic. The problems we faced, however, was that a lot of patients were getting confused at home with reading the oxygen sats and getting the sats mixed up with their heart rate. So that presented quite early on. So what we had to do is devise a patient video. And we did it within 24 hours. By no means was it professional, but we got it out quickly. We popped it on the website so that patients had easy access. And they were just able to really get a good idea of how to monitor their saturations every day, and just had a bit more reassurance. And they knew that if they were feeling unwell, they had the safety net there behind them.
Thanks, Effie.
Yeah.
Joe, if I could ask you to sort of come in now and just talk us through, I think you've done something quite original here around triage, because normally we are quite focused on news for our triage across a whole range of conditions. What if you could talk us through the thinking around how you did things differently here?
Yeah, I think really so we triaged patients according to their oxygen saturations, and at the time this was, I suppose, a little bit controversial, but what we were relying on was all the Italian evidence that they'd sent us their triage pathway, and this seemed to work for them. We put it through our acute medicine and emergency medicine clinical governance, and it was very much approved that for this viremic illness, a single organ illness, it was very reasonable to triage patients based solely on their SATs, as long as we did a walking test to stress them. That's, I think, been a little bit controversial since, but as Andy will come on to regarding the data, it worked.
Okay. And have you had any sort of feedback from people around this sort of different approach around not using news as your upfront marker?
Yeah. So if I come in here, Dan, yeah. I mean, we have obviously, because there was actually a national triage pathway proposed, which actually had news as a large part of it. And I think one of our concerns was that you know, we had a lot of young patients with temperatures, tachycardias, who clearly didn't have COVID pneumonia. And that's really what this pathway was about, is trying to identify those patients who, as opposed to just having upper respiratory tract COVID symptoms, actually had evidence of lung involvement, so had COVID pneumonia. And our feeling was that really, although in the very sick cohort of patients who end up on ITU, they can get a multi-organ problem and can get cardiovascular problems. Actually, in this lower risk group of patients, the predominant cause of deterioration really was due to hypoxic respiratory failure. And so stuff like the cardiovascular side of things and the temperature side of things really weren't as important. As I say, there have been a few discussions with perhaps other interested parties who really wanted to focus more on news score. We weren't saying that we shouldn't be doing news scores. I think we just felt that a news score would probably overcall who needed to come into hospital. And as I say, more through serendipity than planning, it actually worked very well.
Right. So here we've got a really nice sort of flow chart here that I think is a blend, or perhaps starting with the Italian version and how you managed to put it into the English context. Joe, do you want to speak to this?
Yeah, absolutely. So it's quite nice that we've got the Italian and British flags on this, because it was really a collaboration between these sort of two different groups. If I may say their names, you know, Cristiano Pirani and Lorenzo Cristoni, Carlo Arrigo, these wonderful physicians that really sort of helped us by sending us all this material. And here, this triage pathway was quite clever, really. If your SATs were abnormal, so that's the yellow and the red box, then those patients were coming into hospital. But if the SATs were normal, potentially those patients could go home. And then what we need to do with those patients that had normal SATs was walk them, stress them. So we walked them 30 meters, If they dropped their SATs by more than 5%, those patients were coming into hospital. But if they dropped their SATs by less than 5%, those patients could potentially go home. If their imaging was normal, potentially those patients could just go home without, with good safety netting. But if they had abnormal imaging, those are the patients that we put into our COVID ambulatory clinic. So we gave them a SATs probe. We gave them quite a slick patient's leaflet. We sent them home, and then they were followed up for about 5 days, phoned every day by the PA students and supervised by the emergency medicine associate specialists. And at the end of 5 days, if they were getting better, that was fine. And if they weren't, they could be brought back, either brought back to A&E. Sometimes the PA students had to send ambulances out if their SATs were dropping. So it was a system that worked very well.
Makes that as quite seamless, but there were a lot of interventions that we had to do. One of the things that happened quite early on was actually someone read their SATs the wrong way around. So they thought their SATs were 86%, when in fact they were 98%, and that caused a lot of problems. But again, we kind of ironed these things out, and there was lots of, if you like, quality improvement PDSA cycles where we added in new things. Like I say, first the SATs probe, then there was lots of teaching materials. We found that the emergency department staff were not terribly good at necessarily giving the SATs probes out, so we created some more teaching materials to basically show them. So there was a very nice, which you can see on the website, something called Give 3, Take 3. So it was a nice little punchy 1-minute video just showing the emergency department staff what they had to do in terms of giving the SATs probes and giving the patient the information leaflet, and then making sure that they took certain information that they would then put on the electronic referral to us. So it wasn't a seamless thing, but as I say, towards the end, we'd really honed down on how to make this work.
It's such a great applicable triage, and it's worth pausing on this for a moment, because I can give you an example. I got called by a friend last night. I'm short of breath. I've been exposed. Can you come see me? And I grabbed my ultrasound, truck to his house, double mask, wore my gloves, and went and ultrasounded him first. And what was remarkable, he had the worst lung ultrasound I've ever seen. Confluent B lines, disrupted pleural lines, looked awful. But his resting SAT was okay. So what did I do? I took him on your 30-minute walk. And so we walked around for 30 minutes. He didn't drop more than 5%. So I said, okay, we're going to monitor him. I left him in the home. So you can feel very good that your protocol has moved from Italy to England, and then it took that great big jump right over the pond to the United States. And I want to thank you, and he thanks you for that protocol. Otherwise, he'd have been in the emergency room.
I mean, one of the things was everything is on the website. So anyone that wants to sort of, set this up in their locality can do so by just finding all the materials on the websites that we set up. And indeed, we've had quite a lot of messages from quite international sort of queries. And that was really why we set the website up in the first place, just put all the material in one place so that other places could use it.
Okay,
great. I wondered if we could bring in Shwan Maruf from primary care at this point. So Joe, you'd originally set out this quite a nice collaborative sense of how you managed to change the pathways inside the hospital. But I think here we're going to understand about how you managed to make those links, to change it, to make that this integrated, seamless pathway, because that's, I think, the critical thing is how this actually works.
Yeah, I think one of the things that was really nice was we were able to draw in the GPs to help us, and we were very lucky because Shwan locally was really keen to, once he heard about this, was very keen to get involved. And we had to teach them how to do point of care ultrasound, but they were dead keen. Can we go to Shwan, because he's got some great data about the local hot hub.
Okay.
Hi everyone, and thanks Dan. Hi everybody, I'm Shwan. I'm a local primary care physician working in Reading, and I've been working very closely with Joe for the last few months and got to know Andy and everybody quite well. Thank you for giving me the opportunity to speak, and I thought I would just share some of my experiences from a community point of view, and the role we played during this COVID-19 pandemic. So essentially, as the pandemic was evolving in its early stages, it became apparently clear that primary care as a whole could not continue to operate in the way that it has been doing for so many years. There was initially an immediate push towards remote triaging in order to sort of minimize the transmission of the SARS-CoV-2 virus, which in itself led to several challenges within primary care itself. Us as a locality, we all recognize that most practices didn't have the facilities to assess patients with suspected COVID-19 safely, and that a significant proportion of our colleagues were over the age of 65, or we didn't have the correct provisions for personal protective equipment that would allow us to see these patients as individual practices throughout our locality. So sort of with this in mind, locally practices collaborated in developing what was eventually a hot hub, which was purely voluntarily established from all the GPs within our community in order to assess patients with suspected COVID-19. And I think the reason we wanted to do that was, you know, we wanted to have a bit of responsibility and help spread more thinly the anticipated pressures that might have fallen on secondary care services, so our emergency medicine colleagues and our intensive care colleagues. So essentially within 9 days, a bespoke primary care response hub was established and was fully operational thanks to the support of all the GPs within our locality. And it kind of mirrored quite nicely with everything Joe and Andy was doing at the hospital, developing this virtual ambulatory care clinic. And we were approached by Joe and Andy and asked whether we would join them in essentially trying to standardize the way, I think Joe was talking about this earlier, standardize the way we assess patients with COVID-19 and get everybody onto a common pathway, whether they presented directly to the emergency departments or whether they presented through their practices into our assessment hub. And I think introducing POCUS into our assessment was key in the way we managed our COVID-19 patients. And I think I can say in hindsight, it was an incredibly positive decision for myself and my colleagues at the Hot Hub to agree to meet with Joe and start to learn point of care ultrasound. If you look at the slide that's in front of you, this just gives you a rough idea. This is the data that was collated from the first 7 weeks that we were operational. And we managed to see a staggering 641 patients who were all triaged by a physician, and they were concerned that these patients might have COVID-19 and that they needed a face-to-face assessment, which couldn't be done in the community. So they brought them to our hub. Of the 641 patients, 42% were diagnosed with suspected COVID. And of the 271 patients that we suspected might have COVID, we only had to admit 36 of those patients. And I'm pleased to report that unfortunately 2 ended up on ITU, but we didn't have any deaths. So the way we collaborated between primary care and the Hot Hub and what Joe was doing with his ambulatory care pathway was a massive success in my opinion.
So the use of, about the cultural change from using point of care ultrasound, because there are many novel things about what's gone on here in Reading, but GPs using acute diagnostics in this way, and certainly, you know, point of care ultrasound is very, very new. And I wondered if you could tell us a little bit about how that felt in primary care, how your colleagues responded to it, and how you sort of adapted to it, because it is really new.
I think it wasn't a big decision to make from us in the Hot Hub because we had a limited number of physicians working at the Hot Hub, and it was a decision that was made essentially by the 3 leads that were running the Hot Hub. And we felt, after looking at the data that was coming out of Italy about the use of point of care ultrasound and its sensitivity in comparison to CT scanning, we felt it would be neglectful not to introduce it as an adjunct to our assessment. We as primary care physicians have become very fine-tuned at taking risk and accepting clinical decisions based on examination alone. So I think one of the advantages of patients going into A&E was that they were able to get a chest x-ray, for instance. Now, we weren't able to facilitate that in our hub, but knowing that point of care ultrasound was more sensitive than chest x-rays, that gave us a lot more confidence in making certain decisions. And it wasn't the cohort of patients that were clearly very well. They were easy to manage, nor was it the cohort of patients that were clearly very unwell. We admitted those. But the big proportion of our patients were the ones that Joe was talking about, the ones that fit right in the middle, They were physiologically okay, but their symptoms were slightly concerning. And having point of care ultrasound and a virtual ambulatory clinic gave us a lot of confidence, and I think patients really appreciated it. I think we kept a lot of patients out of hospital as a result.
Do you think this is a diagnostic technology that you want to carry on using in your practice?
Absolutely. Absolutely. I think it has the potential to be adapted for other conditions, but certainly as a stepping stone towards that, using point of care ultrasound for COVID-19, as we were taught by the ambulatory care clinic, was a fantastic first step.
Okay, great. So while on the subject of data, I wonder if we could look at the whole cohort of data and ask Andy to sort of speak to the cohort of patients that was seen and managed on the whole pathway.
This data is up till the end of May, because that's the last time we kind of looked at the database in detail. So this is actually this is a total of this is for, as I say, a sense point of right at the end of May. We've actually admitted about another 40 to 50 patients onto the pathway, and I'm not going to go into great detail, but I think there's just some interesting points about the case mix here, which actually kind of illustrates the sort of patients we were following up. So actually, as of, let's say, the end of May, we put 244 patients through the pathway, of which 29 had reattended, and about 18 had been readmitted into hospital. At that point in time, no one had died. In fact, actually, since then, rather sadly, one patient has died, but that's of almost 300 patients that we put on the pathway. And I think that this is an interesting point, actually, because certainly in this country, NHS England and the Ambulatory Emergency Care Network really have quite good criteria of what they would consider a good functioning ambulatory pathway. So for a pathway to be functioning well, you really want a failure rate of about 10%. Because really, if the failure rate's a lot lower than that, then you have to question whether there's any point having an ambulatory pathway, or whether you just discharge these patients back to their GP. Where if the actual failure rate is a lot higher than that, you have to question how safe your pathway is. So there's very clear guidance, again, as I say, from NHSI, and we are at 11% in our reattendance and 8% in our readmission rate. So more through serendipity than actual planning, this pathway actually worked very well. There's some interesting stuff in the data, perhaps completely understandable that actually there's a higher proportion of women on our pathway, probably because more men were actually admitted to hospital because they tended to have a more severe manifestation of the disease. And then it's just worth noting that this wasn't just referrals from the emergency department or the hot hub. In fact, we had a lot of referrals from within the hospital. So some patients that had perhaps coming out of hours where people were unfamiliar with the pathway had been admitted to the acute medical unit, and then the acute medics would see the patients, would go, actually, you look like you're someone that fits the pathway. And so they would go through the process and actually refer on from the acute medical unit. And then also some patients on the wards, so actually on the tail end of their illness, would be discharged as a safety netting by specifically the respiratory physician. So someone who's still got lowish SAT, but looks like they're improving. That was a small number, but actually it helped to get patients out of the hospital quicker as well. What we thought was interesting, and just reiterating this point that Dan was asking earlier, was really this concept of news. And actually, if you look at the data here, although 60% of our patients did have a news score below 3, 40% actually had a news score above 3. And again, if we'd followed national guidance, then most of these patients would have been admitted to hospital. Other things to note were actually at the time that we started this pathway, the PHE guidance was very different about swabbing. So actually it says negative, but that's negative or not sent. So actually, again, at the time that we looked at the data, only 50 patients had actually had a positive swab, whereas actually the vast majority hadn't had a swab, because the advice was if they're in general practice or if you're discharging them home, then you don't do a swab, because there was a shortage at that time. Obviously, things are very different now, and I think if we had a second wave, we would have a lot more data on that. The one other thing to note as well is that, again, on this slide, you can see that the imaging that got the patient onto the pathway was in hospital was predominantly a chest X-ray, a small portion was CT, but the proportion that were ultrasound positive that had got them onto the pathway, the vast majority of these were from the hot hub. And I think 45 patients were referred up from the hot hub, and they'd all had ultrasounds. And it was really, you know, all those patients would probably have had to come in via the emergency department if we hadn't set up that service with Schwann and Boo and the hot hub. So I think that was a real success story. So again, we just, this isn't a clinical trial, but we thought we would have a little bit of a look at what meant that some of the patients got readmitted. Again, this is probably part of a quality improvement thing. We were just trying to identify where are we sending some patients home who shouldn't go home. So again, not surprisingly, a vast proportion or an increase, the majority of the patients who were readmitted were men, whereas actually the women seemed to stay out of hospital, which again reflects what we know about the condition. The news score was slightly higher in the readmitted group, but again, that may well just be reflected by the fact that actually they had a lower, slightly lower starting SATs. And it may be that we might be able to tease out by looking at the data in a little bit more detail and actually stratify patients a little bit more precisely as those are in a lower risk group and those are in a higher risk group, which is something that we are hoping to do. We're doing a regression analysis at the moment. But what is also interesting is that things like the lymphocyte count, which we saw in admitted patient was low, actually in this cohort wasn't, and the white count was very much normal. So I think on the whole, these patients didn't have secondary bacterial infections either. So that's just an overview of the data. We've got quite a bit of data on patient experience and cost avoidance as well. But for the sake of brevity, I didn't want to include that in the talk, but perhaps we could talk about that in the Q&A session.
Thanks. And it's interesting to see several things. So firstly, that there's no upper age limit to ambulatory care. And it's important to see that actually it's about your assessment of the function. And I wonder if element of because we this is also about, you know, care is consensus between clinician and patient. And were there patients that were, if we weren't sure about admission or discharge, was there much of a patient drive to say, actually, I want to go onto this pathway? Do you have those kind of conversations?
Yeah, I mean, I think that most patients, well, I mean, my perception is that as someone who works, you know, as a acute physician for a significant portion of the time, is that the majority of patients don't really want to come into hospital. I mean, I don't know what it's like in other countries, but certainly in our hospital, although we've got fantastic staff and infrastructure and things, pathways and processes, the infrastructure and the fabric is very poor, and you know, patients are spaced quite close together. You know, if you were worried about getting COVID, it's the last place you'd want to be. And so the vast majority of patients I know would much rather be sent home. And I think that this has really helped to kind of supercharge that a bit. And I know we might talk in a bit about the concept of a virtual hospital, but the vast majority of patients who went on this pathway gave fantastic feedback and also really felt reassured. And I think that's a lot of it. It's often a process thing. You know, you send patients home and they just feel a little bit scared because they don't want to necessarily just ring 999 if they're not feeling very well. They want some sort of reassurance. And I think that was perhaps one of the biggest successes of this pathway, was that these patients would go home and they would feel just much, much safer because they knew that they had the SATS probe. So if they felt rough, they could put the SATS probe on and make sure that things were okay. They had a number that they could ring if they got into trouble or they didn't feel well, and that number was available out of hours as well. And I think it was more that the fact that they knew that there was a direct line back into the hospital system, rather than some, I've got to ring 111 again, I've got to go to the hot hub, I've got to go ring 999, all of these different things. Actually, they knew that there was a direct pathway back into the hospital, a back door, if you like, back into the hospital, rather than having to go through the whole usual process. So I think that from the feedback that we've got, it was very clear.
Yeah, I think Dorothy in The Wizard of Oz had it right. There's no place like home, but if she had to make the movie today, there's no place like home with a pulse oximeter. Absolutely.
Yeah. Or maybe something a little bit more high tech. But but definitely a pulse oximeter. Yeah, that's a nice analogy there.
So we've had a question come in that I think now would be a good time to take about the level of training that the people who were in the hot hub were in terms of the lung ultrasound. And I want to, Joe, this is something that obviously you've been taking on. And I can certainly attest to how good the training is in Reading. I learned ultrasound from Andy on one of his courses, so I know that Reading has got a long history of delivering a lot of great training. I wonder if, Joe, you could sort of talk about how you train people, and there's questions coming about what's the level of training for lung ultrasound.
Dan, thanks. I think you're right. I mean, Andy has set up here the famous and the FICE course to run for many years. So there was already embedded in the hospital a real appetite and an understanding about point of care ultrasound. But particularly answering that question, what we did was we realized that we needed to train the GPs who were very keen in lung ultrasound very, very quickly. So what we did was we created this sort of very neat pathway whereby they could triage patients with COVID within the triage pathway TIC19, which was the name of our triage pathway. What they needed to do was a 25-minute video. Watch this. It's on YouTube. It's still there. You can get it through our website. It's 25 minutes about lung changes in COVID. And then after they'd seen that video, they came to the Royal Berks and we showed them how to scan normal for about 30 minutes. In the photo there, you can see that's the guy who does our admin is Jack, and that's him being scanned. So that was the sort of scanning normal. And then we did 30 minutes of abnormal. So the way we did this, we've got a piece of tech called Eve2, which is a sort of sim for ultrasound. You put the probe on and then it shows you images of what's there, and you can set it to show different pathologies. And the other thing we did was we looked at the images in our butterfly cloud of patients with COVID. So I think the cloud was a very useful thing, so that when then the GPs went away, having done this 90-minute session, they could scan patients and send their images to me and Andy really easily over the cloud. On my phone, it would come up with a little message saying that they've sent an image across, and then I could just look at it and say what the report was, whether they got it right or wrong. And after about 10 scans, they were actually, you know, I have to say they were very, very good at being able to triage patients with COVID. They picked it up very, very quickly indeed. So at that point, then they got a sort of assessment. So I went over to the hot hub and assessed them in person.
Can I just come in here as well? So I think that's one of the essences, is that because there was a lot of anxiety amongst a lot of our colleagues, respiratory colleagues, acute medicine colleagues, about what we were proposing. And I think there was a fundamental misunderstanding, is that what we weren't proposing is that we were training people up to be completely competent in point of care lung ultrasound. You know, that's something that needs a period of training, seeing a wide range of pathologies, and you know, it takes actually quite a long time to become properly competent at. But what we were using here was we were using this as a dichotomous decision-making tool. So what we were really teaching was we were teaching what is normal, okay? And if in a pandemic you scan someone and the lung ultrasound is not normal, then that patient almost certainly is going to have COVID if they've come in with a very high pretest probability. So that was our sort of thinking. But then inevitably, you know, when people are doing things a lot, they get very good at it. So I don't know whether Siobhan, you want to come in here, but I know you diagnosed some other things just kind of fairly intuitively, didn't you? Because you picked up some pleural effusions, you picked up someone with heart failure, and we hadn't really taught you about that, but it was just very, very intuitive, having scanned a lot of patients. I don't know whether Siobhan wants to talk about that.
I think if you speak to different people, they might have different opinions, but for me, it was a very addictive process. Once I got the taste for COVID, it sort of made me a bit more interested in lung ultrasound, and I spent some time sort of reading online and just generally trying to improve my own skills. But like Andy was saying, you know, we managed to pick up some different pathologies that may or may not have been related to COVID, but that all came with time. And I think, like Joe was saying, it took some scans before we felt competent to do it. But having that as an adjunct to our assessment was very, very helpful. And I think the most important thing to take away is that Joe and Andy didn't teach us lung ultrasound. It was very much, this is what normal lung looks like, and this is what COVID looks like. And just to give you an idea, about 75% of our fit and healthy patients who examined normally went on to have ultrasound changes consistent with COVID in its early stages that we were able to then put onto the ambulatory care pathway, and they could be monitored in case they deteriorated. And I think that was the whole point of doing it, and I think it worked and it was a success.
I think this is a point that's really worth pausing about, because we get this addressed very often in actually teaching point of care ultrasound. And it is an incredibly intimidating thought to learn all of point of care ultrasound. But as we start to embrace this and add this into our practices, being very focused on what you're learning. So in this situation, what does normal look like and what does abnormal look like for COVID? You can apply that again for, let's take a patient that comes in with a known history of congestive heart failure. What does normal look like and what does heart failure look like? You can learn that really quickly. And so we kind of have this mindset of land and expand. Learn these simple things easy, get good at them. And as you do it more and more and more often, you begin to expand your portfolio of what you feel confident doing and what you feel as if you have to refer up for a higher level of imaging. And I think as we embrace point of care ultrasound across a diversity of conditions, I think that's part of the message that you've taught us in this experience, is that you can start small and grow.
Yeah, I mean, so can I just come in? Can I just come in as well again? I mean, I think one of the things that, I mean, I've been doing point of care ultrasound for about 12 years now, and I've had lots and lots of battles with radiologists and sonographers over the years, because they're just like, well, what on earth are you doing? You've not had any training, you don't know what you're doing. And then, you know, it really is that sort of penny dropping when they realize that what we're not trying to do is reproduce what they're doing in the department. What we're doing is we're integrating the point of care ultrasound into a clinical pathway. So we've examined that, we've taken a history from the patient, we've examined them, we've got some blood tests. We have often have a very specific question we want to answer, and it's often quite dichotomous. So it's not like I've got to reach this point, so I've got to do a full echo. It's like, I've reached this point, I've got a shocked patient, I'm not certain what's going on here. So what I need to do is I need to just put the probe on and follow an algorithm to work out what the cause of their shock is. And I think once they start to understand that we're using it in a very different way, they've kind of got on board. And certainly in this country, I don't know, the States are probably a bit ahead of us, but in this country, I think they've started to get on board with what we're proposing. And you know, the technology is so disruptive that they don't really have a choice, because when you can, you know, put an ultrasound probe in your pocket, people are going to use them. And so it's much better if they're on board, you know, at the forefront, and actually, you know, having their say rather than us just doing it all on our own.
Andy, could I ask you just your view around how you think that the technology and image sharing has supported the development of this work?
The image, so I mean, that, you know, I know that obviously this is sponsored by Butterfly, but I've got no conflict of interest here. I genuinely think that I was a bit skeptical initially when I saw the Butterfly probes, because I thought, well, I've always been a bit of a refusenick around sort of Apple technology and stuff like that. I've always gone for Android, and I just thought it was a bit sort of it jarred with me a little bit, but that's just me. But actually, you know, obviously once I started using it, I realized the pictures were excellent, and actually the ergonomics were good. But the thing that really changed it for me was the idea of this cloud, because one of my problems as a fairly lone point of care ultrasound trainer is that I get asked by so many people to act as a mentor or a supervisor, and you know, I want to help people, because I want people to learn this, but you know, there's a limit to the number of people I can supervise or mentor at any one time. But with this, you know, like having the cloud, it's just great. I can be checking my emails, and then someone can just, and then an email pops up, you know, saying, can you review the scan? I just literally click on the link. There's a comment there. I can just comment on it, and then that job's done. Rather than someone turning up with a memory stick with like 30 scans that they want to go through on a Friday afternoon, and it's just like your heart sinks, your head drops. You know, so this, I can see that as a training tool, this is fantastic, because you can train people properly in real time, and rather than them come after they've done 10 or 15 scans, you can pick up where they're going wrong earlier as well. So you can go, well, look, you've not got enough depth there, or you know, your gain's too high, turn the gain down, you know, and you see in real time with each scan, you can actually remotely supervise in probably a more constructive way.
We're teaching the physios here how to do lung ultrasound, and one of the things that's really helped is we meet once a week with the 3 physios, and we go through their images on the butterfly cloud, and we're able to give that kind of real-time feedback to them about the images, and then show them other images from other patients so they can see different pathologies. It's a very simple kind of process just to pull the screen up and have a look.
You can tell us how you use social media inside the hospital as well, because that's quite a complex community as well to influence and to get support from.
We were really well supported by our comms team, particularly Victoria and Sally, who I think are watching this. And, you know, every time that there was a problem, like for instance, in A&E, it was really busy for those guys, and they had a lot of priorities. And the priority for us was that the patients went home with a SATS probe and a patient leaflet and a decent phone number that worked. But clearly in A&E, they've got lots of different priorities. So one of the things comms did, we made a video for how to refer onto our pathway, just a 30-second video, how to use our pathway, how to refer patients into our COVID ambulatory clinic. And the comms team sent this out to the entire hospital, so everyone would know. And everyone would know that this pathway existed. So they really helped to sort of get this message out. And then one of the other things they've done is they've really supported us through retweeting our tweets. And so one of the things we've learned during COVID is we've all learned how to do Twitter and the difference between a hashtag and an @ sign and all that. We're sort of getting a hang of that.
So the one thing that I kind of, when I look at this picture of the 3 of you now, is that you're all at different stages and across disciplines. And I don't see a hierarchy when I see the 3 of you on this screen now. And I wonder if you could sort of talk a little bit about that and about how that sort of changed how you work in this pathway.
Yes, correct. That's correct, Dan, because this is why I love this hospital so much, because there's no airs and graces. You know, being a PA student, you get stick being a student, but here, both Andy and Joe gave me the opportunity to be part of this, which is it's an honor and a great opportunity to do so. But they take your ideas on board and you're just able to implement your ideas. So it doesn't matter if you're a consultant or if you're a doctor or if you're a student, your idea matters, and that's why I love it here so much.
I think one of the things that we had that was very successful was the PAs are well embedded in this hospital. We've had a PA program for a few years, and so when this all started, we needed helpers very quickly. So there was a kind of an appetite to create a little video to advertise to the PA students to come and work for us, and it was really quite moving when they accepted. They just volunteered to come and work in this COVID ambulatory clinic. And, you know, I mean, one of the things like Afi and one of her colleagues, Dion, one day they said to me they had this idea to go to the pharmacy in the hospital to see whether they could get a way to, they'd had a patient who needed some antibiotics delivered, and they'd normally have to go through the GP. And they said, well, maybe there's a way to get these antibiotics to the patient. So they went to the pharmacy, spoke to them there. And what they were able to do was to kind of piggyback on the same pathway that existed for patients with cancer during COVID, where the antibiotics would be driven to the patient's house or whatever medication it was and put through their front door. And so the next day, this was all up and running. And we tried it on the first patient, and the patient needed antibiotics. It just happened a few days later, you know. And 2 hours later, the antibiotics were put through the patient's door, and the patient was absolutely delighted with the service. And we wouldn't have thought to do that, but the PA students did, and they just ran with it, and it worked really well.
And what about the culture of the organisation more broadly? I mean, at the beginning, Joe, you were sort of talking about how you kind of got some time on the exec corridor and the support for that, but it's sort of, that's not the easiest thing to do. So I wonder if you've got any reflections on the organisational culture within the hospital. I guess I should also say I'm not employed by the Royal Berk, so I'm saying these positive things because I'm seeing good things in front of me, not because I'm on your team. But what if you could sort of tell us a little bit about that organisational culture before COVID?
Yeah, I mean, I think, yeah, I mean, I've been here for 10 years, and I think in a lot of organisations, often management and clinicians work in silos, but here actually it's much more integrated, and you know, like the fact that we had an idea and we just kind of got the lift up to the exec floor and just like stormed through. Where's the coup? You know, where's the chief operating officer? And we went down and we got knocked on his door, went to his office, and rather than him being put about, he said, well, tell me what your idea is. He got the chief medical officer in, and then myself, Joe, and Georgie, our matron, just said, well, look, we just think this was right at the beginning. We just think this would be a fantastic way of taking the pressure off the emergency department, taking the pressure off the beds in the hospital, because this was at a time when we thought that we were literally going to be inundated. And they were great, and they said, yeah, okay, well, let's give it a go, and to have that rather than, I've spoken to a lot of colleagues in other organisations where they've tried to set up a similar thing, and just the first person they speak to about it says no, and I think that really, as I say, I have got a lot of time for our management structure, our exec, because I think that they genuinely kind of work with the clinicians to try and make the patient care as good as possible.
And what about having a culture of point-of-care ultrasound? As you say, you've been doing a lot of clinical care with ultrasound in Reading, a very early adopter of the technology in acute internal medicine. And so people across the hospital, the CMO included, will have seen you in operation and making decisions with the probe in your hand at the bedside. How important do you think that was in saying, and now we're doing the next phase, we're taking it outside the hospital?
Yeah, obviously, as I said to you, I've had a lot of battles over the years, but I've got my own way in the end. So we're very integrated now with the radiology department. So the radiology department will provide, the sonographers will provide training for the ultrasound fellows here. We're very integrated with the cardiology department. They were very happy when we gave them a couple of the butterfly probes as well. And they can see the value in that as well. And so that culture has kind of been embedded over, and that's not just down to me. That's actually there's cardiologists who are quite forward thinking. There's radiologists who are forward thinking, and we've kind of triangulated, if you like. And but that is great. And our chief medical officer has seen me scan patients and actually seen the difference it's made to those patients. So obviously that makes it a lot easier when you're going up to discuss those sorts of things, rather than you going, we want to get the point of care ultrasound, and they'll just go, what? They actually, she knows what it is, and she's seen it used, and she can see the value in it.
This is such an important point, because so often in hospitals across the country and across the world, innovation, the first thing it meets is 25 committees, 50 people having to approve. And if you want to innovate and change and learn quickly, you just can't have that process. And, there's so many things we do in medicine today that 10 years ago were somebody's no, that are now just don't even think twice about it. I'm scared to say I'm old enough to remember that, someone other than a highly trained person doing a glucose stick to find out what the patient's glucose was, you had to go through an advanced training course, you had to be signed off, and you had to nearly be the Secretary of Health and Human Services to perform that inside a hospital. Now every patient is doing it. Or take, for instance, a defibrillator. God forbid Joe Schmo on the street would pick up a defibrillator and shock somebody. Nowadays, it's, second nature. And I think what's really unique about what your situation is, and what it's so important why everybody should look at is that you were not afraid to try something new. You had great baseline skills that had the safety and efficacy in mind, but you were willing to experiment. And that's how we move the ball forward. And I think it's for people like you and the lessons you've learned, and to share them everywhere, to know that healthcare has got to move forward. And I'll look in the United States as an example. Our healthcare systems got hammered. They have hemorrhaged money, and they're behind. And if they think they're going to catch up practicing medicine the way we used to practice medicine, it's a fool's errand there. We've got to take this one opportunity of COVID to say, we were just given a gift to practice medicine differently. We got a kick in the butt to move forward. And you guys took advantage of it and ran forward. The goal is for the rest of us to run right in your wake, and we all continue to learn and advance this forward. And I hope everybody goes to your website, and hope everybody learns from you, because you've made healthcare better in your community. And now it's important for us to take that around the world.
And I guess that also leads us on, we think, well, the future, what's next? So you've done a lot of work, and you've made a lot of things change. And I think, well, actually now, where's your focus? It's kind of like, if you do one great thing, then everyone goes, okay, what's your next trick? But I think, Joe, do you want to just pick up firstly around the POCUS Academy? Because we've had a question come in around people saying, where do we go to learn more? I mean, Andy, you've already said that because there's a challenge, because everyone wants to come to you to be taught from the master. But I wonder if you could tell us a bit more about the POCUS Academy and how you see that meeting a big need for training in this country.
Yeah, I mean, it does seem to be, it's very difficult to get signed off in these skills. And you kind of, if you want to learn point of care ultrasound, you have to go on a course, and then after the course, you have to do a certain number of scans, and then you get signed off. It's a good system, but it's quite difficult to get signed off. So what we did with this was, by creating this pathway for using lung ultrasound in COVID, we kind of broke it down a little bit. We made it simpler, but also made it change the management of the patients. So one of the things we're going to do at the Royal Berkshire Hospital is Andy and I are founding a POCUS Academy, whereby we want to sort of build on what we've established so far in terms of the teaching lung ultrasound. And one of the other things we've done is we've started teaching vascular access under ultrasound guidance to nurses, and they just love it. There's one of our nurses is Harriet, and she says the butterfly IQ is her favorite piece of kit. And they just love having this extra skill that they can do that other nurses can't do. So we want to build on this in terms of teaching vascular access, because it's a really important skill for improving vessel health in terms of lung ultrasound and echoes, and then abdominal ultrasound. And so practically how we're going to do this, one of the things we're quite excited about, although it's going to be a lot of work, is we're setting up with the other people in the hospital who are doing ultrasound, we're setting up ultra rounds, which are ultrasound grand rounds, so that we can bring out interesting cases that we've seen, and then we can discuss them. We can look at papers related to that to try and make POCUS something that is less something that just a few people in the department do, to something that we can all sort of potentially, if you're interested in, you can have a go at.
And Afi, can I ask you about whether this is something that you're going to be taking on board as part of a physician associate service?
Yeah, well, Dan, I'm coming towards the end of my course now, so I'm hoping to get a job at the RBH. So I'm hoping that part of my job spec will be doing point of care ultrasound. So just depends on if I get a job.
Don't worry, Afi, it's in the bag.
I think I like your
Yeah, most definitely.
I think I like her chances. John, where do you go from here? You know, you've had a COVID experience. Now, where do you go from here? Are you gonna move off the lungs and go somewhere else? You know, visit another part of the country here with your ultrasound device? Where do you go from here, and how are you going to influence your colleagues in primary care around the globe?
I think one of the things that we need to do, you know, we've had this success, and it's great, it's been fantastic, but we mustn't lose kind of, although we're all looking forward on the 4th of July to when the hotels open, we can all go on holiday. But after then, I think we've got to kind of continue, if I may say, riding this wave of sort of success regarding point of care ultrasound, and see, for instance, you know, there's the role of ultrasound in primary care, I think will be a very important thing going forward. In many ways, probably more important than in secondary care. So we'd like to work with others like Palmy in Chelsea and Westminster, who's a GP who's very into POCUS for GPs. This is an important thing that we've just got to try and roll out more widely, I think.
I think, you know, we're looking at, you know, obviously the point of care ultrasound aspect to it as well, but is actually trying to harness some additional technology, so around the SATS probes, you know, and actually looking maybe at other monitoring devices, and actually looking more at, you know, can we actually spread this out to other patient groups? You know, could we actually be managing more patients out in the community in their own homes with remote monitoring? Because, as I say, I think that's what the patients want. I mean, I think this is a consumer-driven society. The patients are our consumers, and what we should be doing is actually trying to live up to their expectations. And I think their expectations are that if they could be managed at home, they would prefer that. So, and often people don't get asked. That's the thing. But actually, when I ask most patients, would you rather go home? They always go yes. You know, very rarely do they say no. And yeah, so it's I think that's like a virtual hospital. And maybe like more GPs out going around seeing sick patients, consulting directly with clinicians in the hospital, trying to streamline pathways and actually maybe keep more patients out of hospital.
We had a question about low middle income countries and whether, what are your views about having imaging through ultrasound in those settings?
Well, that's a no-brainer, Dan, isn't it? I mean, I've been lucky enough to have been out in the Democratic Republic of Congo back in December last year, working on a research project there, looking at using lung ultrasound in children to look for complications of malaria. And, you know, you can just see it's kind of complete game changer, you know, because once you've bought the probe and you've trained the person, then really it's kind of like, it's a free-for-all, you know. I mean, it's kind of like, you know, all these people who can't afford to access chest x-rays, CT scans, if you've got something that perhaps isn't quite as good as a CT scan, but is better than nothing, then that's got to be a good thing. So I think that's, you know, that's huge potential there for improving healthcare in resource poor countries.
We've had some comments come in there about the terrific effort, guys. Very proud. You should, so people are recognising the PAN system changes that you've made, and as I say, it's quite unique to have such an integration in acute decision making in real time across primary and secondary care. It's really, really special, and it's certainly not really been done in this way at all before, and certainly not with this very sort of enabling technology either. And yeah, and so we've got a last question here. I think will be whether perhaps you and also Xuan could come in. So, any thoughts on POCUS ultrasound being used for home visits for shielded patients in primary care? What do you think, Xuan?
I think just as the numbers of COVID patients were starting to come down within our locality, there was already talks about a domiciliary visiting service that primarily was going to be run by a handful of primary care physicians. And we had hoped that if that service was required, that it might integrate with one of the GPs who was working at the hub, or the plan was to send the volunteer GPs doing that service over to Joe to get trained up to do lung ultrasound. I don't think there is any reason why we shouldn't be doing that if we can do. The key has to be keep the patients at home if they're safer there. And I think if we can facilitate that with a visiting service, we already do some visiting as part of our sort of core work in primary care. I know the circumstances are unique with COVID-19, but I can't imagine we would have significant numbers that were not ambulatory enough to get to our hot hub. But we should be able to facilitate that should a second wave come again.
We've got time for one last question. I want to pick this out because it's quite an important one, and this is for sort of Joe, Afi, and Andy to scratch their heads on. So that makes the point that okay, we're using the oxygenation of the patient as a critical thing for triage. But what about some kind of scoring system that you think could be developed around the lung ultrasound findings? Do you get a sense, Andy or Joe, that actually, say, the extent of changes that you're seeing on ultrasound, is that correlated with outcome? Is that some marker you could use to sort of for triage as well? I wonder if you've got any thoughts on that.
Well, I mean, I have had thoughts. I mean, I think it would be a really interesting study to do, wouldn't it? It would be to look at the degree of changes on ultrasound when you first assess the patient and what actually happens to them, not just in the ones that are being discharged from hospital, but also the ones that are being admitted to hospital, but being admitted as well. Because obviously, if you could tell from the ultrasound on admission who's likely to end up needing to go to ITU, and also actually, so I was using it when I was up on intensive care to sometimes guide some of the manoeuvres that we were using as well. So if someone had predominantly posterior lung disease, then the likelihood of them benefiting from proning was going to be a lot higher than if they had disease that affected the anterior and the posterior segments. So while it wouldn't necessarily mean that I wouldn't prone, I think it would kind of guide me as to how likely the proning is to help. And I think that would be a really interesting thing to look at in a more controlled way, obviously, assuming that we do get a second wave. Or maybe they could do that in America, in the southern states, because it looks like That's definitely kicking off, isn't it?
Nice shot. Nice shot. Very well played.
No, guys. So we've kind of our questions have now finished. We've answered all the questions that have come in. We've had quite an amazing discussion and review over what you guys have managed to achieve in an incredibly short space of time across a complex system. And you know, we've got some critical enablers. The technology has clearly been an amazing enabler, but you've had the right culture and context around it, and that all those moons have lined up. I wonder if you've got any last thoughts from the Reading team, first of all, from RBH.
I think it's really exciting. We're at a very, it's been an exciting time to be one of the ultrasound fellows at the Royal Berks. And I think, you know, the next project for us here at the Royal Berks, the big next project will be the virtual hospital. I think point of care ultrasound, point of care blood test will be very integral to that.
Yeah, no, I'd say I think that's really where we're going to take this next, assuming that we don't have a second wave. But you know, that's a big assumption, isn't it? Although at the moment, yeah, we're struggling to find COVID patients to put onto the pathway. So we'll have to see what happens after July the 4th.
You're certainly ready and primed for whatever happens next. That's for sure. Siobhan, any last thoughts from you?
I think there's a bright future for the model that we have used as a foundation at the moment, and I think it definitely can be extrapolated to cover a sort of a wider array of diseases and presentations outside of COVID-19. I think there is a huge need for a primary secondary care interface service, and I think point of care ultrasound is going to be integral to achieving that.
Yeah, I think that's right. John, I think I'm going to hand over to you, John, for the kind of final words and for your overall kind of reflections on what you've heard tonight.
Well, I want to start with a thank you for all of you, Andy, Joe, and Afi, and Trami, and Professor. You know, we feel very fortunate at Butterfly to be working with people like yourselves. You know, there are often times when the right technology meets the right people in the right situation. And I think this is a great example of that. And I think you've taken full advantage of it and it's set an example. And I think there's places to go from here. I mean, congestive heart failure is a massive problem around the world. It's expanding rapidly. And this is a tool that can be perfect for CHF. And I'd be really excited to see if you guys could apply this to try to move the congestive heart failure patients from coming back frequently to the hospital. And I think there's a great opportunity for that. And we look to see you in other areas and how you're going to accelerate education with Siobhan and other primary care doctors, because we need to learn from that as well. We'll share this hour with people across on our website. We refer people to your website to learn from you, to butterflynetwork.com for information from our site. And we look forward to hearing what the future holds from you guys. And we're going to follow it closely, and we'll look on Twitter to find out if Afi got a job, because we're confident now that it will be posted there. And we want to thank you all again, part of what has been a very, very special hour. And congratulations to you all. You should be very proud of the work that you've done.
Thanks, everyone.
Thank you.
Enjoy your evening.